are running a bit behind schedule, so thank you very much.
Thank you.
Yep. But I would like to call our surgeons from our last session up just for a short question and answer panel, especially questions from this side. If there's any questions at all that you can ask these experts to come up and educate you would be great. And we'll have to limit this just with respect to time, but there is time for one or two questions. I'm going to go ahead and kick it off with you guys. So we heard a lot about scoliosis treatment, right? Where do you think all this is headed? What's the future of treatment over the next few years? Or what are some of the latest, technologies, whether it's low-dose radiation, understanding 3D? If you guys can just elaborate a little bit more on that. Mike, do you want to kick it off from that end?
Yeah, sure. So I think we have horizons for leaps in technology and what we're doing. I think the sort of closest term horizon is being able to do some sort of progression prediction, which I think will be very important for you when you come to the clinic, so that if we can get you more accurate information about what to expect in the next 3 or 4 years. As we say, brace, don't brace, maybe do surgery, start thinking about surgery. I think that's going to be very important for you. I think it's going to be a little while before we have a real strong biological break, and where we understand what causes idiopathic scoliosis, which probably has hundreds of different causes that we don't know. I think that is sort of the pie in the sky. And while I gave the non-operative talk, I think other even closer term horizon to progression is understanding that as groups like this work together and we get best practices together and institutions do things called perioperative surgical homes where we're dedicated to the care of the disease, we have standard processes. It's the variability in care that really drives sort of complications in medicine. And as we move forward and we get all our ideas together and we accept what are the standards of care, the surgeries we provide, I think, are safer. You get out of the hospital faster, and your overall care is better, I think. So that's the closest term, is that we're all finally getting a real consensus on how, not just to operate, how to take care of you after the surgery, and then also with shared decision-making, how to expect things, both with surgery and non-surgery. I think that's the most important right now.
That's excellent. We can go down the road, but I'd love to make sure that any of your questions that you may have. Anybody at all? Yes, please, go ahead.
Piggyback on what you just said, I think it was in your speech. I think in your speech you were saying, 20 years down the road, if you didn't advance, it wouldn't be good for the practice. And then you said something about a 100-degree curve that would be necessary. What is the cutoff, do you think, on the curve, and how long do you put off surgery?
So in my hands in my practice, in part because I also do adults, I say 80 degrees is the cutoff. So I'll let patients watch it up to 80 degrees. But after 80 degrees, I think that the risks of the surgery, while it's still idiopathic scoliosis, the likelihood of something bad is small. It's probably slightly elevated. And I think also that the progression of an 80-degree curve is just so different than the progression of a 50-degree curve. That an 80-degree curve in 20 years is going to be 100. That's going to be in the prime of your life. It's difficult to take time off of work. It's harder to recover from adult surgery. So I say 80, but I don't
Does
see
anybody
what
else want to comment? Go ahead, Dr. George. Steve, you want to?
Yeah. It's a great question, and I would say a lot of times I don't actually use a number as much as the type of curve. So some of the data that we do have is that if you can limit the extent of the surgery, the extent of the fusion to, say, the upper portion of the spine rather than the lower portion or just the lower portion, that the outcomes are likely better because you're maintaining some flexibility in the other areas of the spine. So while the number is certainly important, I think if the risk of creating a double curve from a single curve exists, that I think that operating a little bit earlier, where the surgery is quicker, the blood loss is less, the perioperative complications are less, to me has always made sense. So I think that's a major category, at least in patients who I take care of, where I will be a little bit more, quote, aggressive to actually be conservative in the long run by shortening the extent of their fusion.
If you're able to do something today that leads to a safer, shorter surgery, do it today.
Yeah.
I saw another hand pop up. Yes, please.
Mine is not so much a question, it's more like a comment. When one of my daughters had her surgery, I was in shock because we decided to post it kind of she felt like she could help others. We put it on Instagram and Facebook. The amount of people who contacted us who were in the same situation with early teens that didn't know what to do was shocking to me. I don't understand why in 4th, maybe 5th grade, the children aren't being checked. Like, is there a standard that can be implemented into the schools where they're checked? Because the pediatricians obviously are not making a big deal about it. So maybe in the school, because I remember back in the day when I went to high school, 9th grade, you had a checkup. You wanted to play any sports, and that's where most people were diagnosed, not a big deal. Then you were recommended to go see a specialist. How come, like, maybe not in middle school, they're not being checked?
Yeah, great.
Because my kids could have been braced.
Yes,
Well, that's a great question, and it's kind of something we're still working on, and it has to do with the cost of actually evaluating or screening kids and whether the number needed to treat, what that cost analysis is. And basically, it's fallen out of favor a little bit because the number needed to treat or to implement these structured programs for screening is so high, and what the thought is that the patients who will eventually need an intervention or will eventually need surgery will be found along the way, and that it's not worth the money to start screening everybody. And there's ambiguity or amongst those of us who treat this. There is no conclusion as to where we stand on it.
Yeah.
Just real quick, I'm in Georgia. So in Georgia, it's mandated that children get screened in the public school system, but not in the private school system because it has to do with funding. And I was involved with this early on. We had a telemedicine program because we're in Atlanta, and if you know Georgia, it's sort of Atlanta and then a bunch of small cities outside of it. And so we would do telemedicine screens where I would sit in an office and have a camera pointed, and they would have kids come in and walk and bend over and whatnot. But what I realized out of that is that so much of that depends on the resources available to the school. So the majority of the nurses who were doing it had never been trained in it, had maybe read online, and I think the biggest challenge, like Dr. George was saying, is that it's so challenging if you think of the number of elementary and middle schools that are out there. Even though we mandated, it doesn't mean that there's any consistency because there's not enough funding to train them. So there have been a lot of studies that have looked at the benefits of it, but just from a pure resource standpoint, even if we had the money and we've said that it was always important, it's hard to find enough train people to do this as exams.
Go ahead, yes.
Just quickly, one of the things that happened is that it used to be that screening was available in most schools, even in Canada. And one of the issues is that when the government looked at this and said, we won't pay for it because it's so expensive to do, they didn't have a good treatment. Bracing was not something that was validated as being efficient and could be used. Nowadays that we have the New England data or the brace study, we're thinking that we should go back, but the issue now is that all nurses are out of the school. Like in Canada, you can't find a nurse in the school. So we're trying to find other ways. So one of my partners in Montreal, he's trying to reestablish the screening, but through pediatricians or nurses or another way of doing it. So we have even ways of putting in the hands of the parents at some point to be able to do it. So, and Australia has come up with a way of, they're sending in a letter to parents, and they built this small scoliometer out of the paper that they get, and then they put it on the back of the paper, their children, and they screen their own children.
Great.
So I think we're going to move at some point towards this, because we have bracing now that we know works.
Excellent. Thank you, Stefan. Let's wrap it up with one last question. We see a hand back here. Yeah.
Hi, yes. Answering your question, I used to work at Dade County Public School. Honestly, they do have it. It's just for low-income schools. So those children are getting screened, but then the report isn't going to the parent after they screen them, or the kid doesn't give it to the parent. So in our case, my nephew, he was screened since 5th grade. But us thinking, it's nothing, it's not really serious, he's walking, it wasn't visible. You'd have to see him bend down for you to see it. So that's why we waited longer than we technically were supposed to. And then, but lucky for him, he met Nicole and Dr. George, and, that's an amazing, for us, we're just like, that's our new best friends. And we're like, oh my God, you guys are great. Yep. But no, they do have it, but basically the better your school is, likelihood you don't have it. You're not going to get screened.
Excellent. Well, thank you for sharing that with us. I'd like to thank our panelists. Good job, guys. Really nice job. And, whenever you put an